I'm going to go ahead and get started. My name is Sue Grinnell, and I'm excited for our call today. And this is one of 11 different interactions that we're having over the course of this year that's focused on sustainability. Today, we're going to have Liz Baxter speak with us. She is from the great state of Washington, Northbound Accountable Communities for Health. And to get us started, we just have a real quick check-in that we'd like you to put into the chat box. Arpane, can you go to the next slide? If you could just write in your name and what's your personal weather status today? How are you feeling? Are you feeling sunny, foggy, a little chilly? Just real quick, just put that in, your name and how are you feeling? Like, what's your weather status?
Did you smell it again?
I'm sorry? Oh, good. It's sunny in Bellingham. Very sunny. Marvin, you look like you're on an airplane. Great. Almost sunny. It's never sunny in Humboldt, right? Great. Well, thanks for joining. We have a lot to cover today, so I'm going to go ahead and transition to Jeremy to get us kicked off.
Great, thanks, Sue. Hi, everyone. This is Jeremy in partly cloudy. Actually, now it's looking sunnier, Berkeley. Thanks, everyone, for jumping on. We do have a lot to cover, so I'm going to be pretty quick in my intro here. But I want to orient us to where we are in our sustainability work and then introduce Liz, and I'll hand it over to her. We're going to spend most of the first hour with Liz. Encourage you as she's talking to use the chat to type in questions. I'm sure there are going to be a lot, and we'll try and get to them at a couple of different points. And then the second part of our time together, we're going to take a short but deeper dive into CARES Act funding and where there may be some opportunities in that realm, and hear from a couple of sites about their experiences there. So let's go to the next slide. Thank you. So at the risk of being a little bit repetitive, this is our schedule for the year. You'll see where we are here, talking about membership model. July, August is primarily check-ins. Definitely, as you're having questions, developing your sustainability work, talk with your cohort leads. It's an opportunity to sort of advance some of the goals we've set. Then we'll have a cohort session in September, and also go over in some more detail the plan for November and the pitch presentations at the convening in November, and then have another cohort check-in in October, kind of in the lead up there. Let's go to the next slide. Great. So continuing to work towards answering the 5 core sustainability questions. It seems to be working relatively well, and we're all working on them in different orders and in different ways, but it's kind of an overall frame for what we're doing. Next slide. And using the cohorts to kind of set this cadence of setting goals, revisiting them every couple of months. So again, do please reach out to those who are leading those cohort groups as you're sort of trying to achieve these goals moving forward. Next slide. Great. I've had a couple of questions about the pitch presentations, and as I said, we'll sort of build in some time to both go over what that's going to look like and to talk specifically in support of your pitch development. But there are 2 resources up on Networks for Purpose right now that you may want to check out. The one on the left here is a sample pitch, really simple, that we put together, both a blank template and then an example for a fictional ACH. This is kind of just drawing on those 5 questions, how to bring it into one place. I'm assuming that most of you will have more complicated pitches or slightly different, but this will give sort of a flavor. And then the one on the right is some guidance just on developing a compelling pitch, pulled from a lot of other resources that are out and about how to develop a pitch. So we sort of synthesize that down into a short set of slides with some guidance and questions. So again, I'll go over these in more detail as we get closer, but feel free to check them out at any point. Great, let's move on to our presentation. I'm really excited for this presentation. Builds on, we've had a number of these presentations about the different funding approaches from Kitty and the team in San Diego on neighborhood networks, Mark Watson on private capital, and a bit on pay for success. And today we get to hear from Liz Baxter, who's the CEO of the North Sound ACH in Washington. So it's great to have a chance actually for the cross ACH learning, sort of stick our heads up a little bit and see we're all part of kind of the same movement. There's definitely some differences you'll see as Liz presents, I think, in terms of kind of the models and even the inceptions of the different initiatives, foundation funded versus built into the state's public healthcare infrastructure and Medicaid. But the values and the goals are really similar. I think you'll see that too. And I'll say from the outset of CACHI, felt like a membership model could make a lot of sense for CACHI sites as a way to kind of bring this notion of shared accountability to funding as well. But I was having a really hard time. I've had a really hard time finding really good models and specifics about how to do that in the field. And a few months ago, I think she's on, Dora Hughes from the Funders Forum connected me with Liz. And I've just been so excited to see some of what they're doing and learn from it. And now I'm excited for all of you to see it too, and how they've kind of worked through some of those details of what a membership model looks like. So with that, I think I'll turn it over to Liz. Again, we'll have time for questions at the end, but chat them in as they come up so we don't miss anything. So Liz, all yours.
Awesome. Thank you so much. I feel like I have been hyped beyond what I might deliver. So I'm hoping that you all have a lot of forgiveness and grace in this, because, you know, I think as I shared with Jeremy last week, you know, we are in the formative stages of developing this. So what you're going to see is something, you know, that literally was presented to our board for the first time on June 26th. And so they are seeing themselves doing some pretty deep thinking about these strategies over the next 6 months and would like to vote on them by the end of the year. So you're seeing it before they've made any decisions, and just to kind of frame it in that way. And I thought it might be helpful, and I'm probably not going to go into as much detail as I typically would on the background, but just to have a frame of reference for how Washington's ACHs are set up. And I don't know if somebody else is going to do moving the slides. So if so, we'll go to the next one. So Washington State is divided into 9 regions. There are 2 regions that have a single county in their ACH, and that is Pierce County, just south of the Seattle area, and King County, which has Seattle. The rest of us are all multi-county ACHs. I happen to have the one claim to fame that 2 of my counties are separated from the mainland by a body of water. And so when we talk about remote and rural access, they get really interesting when you are dependent on a ferry system and or life flights and such in order to access urgent and emergent care. So the regions, obviously lots of rural, as you get kind of east of I-5, which runs from where you see Southwest ACH all the way up to the Canadian border. And anything that's really much east or west of that is a pretty rural parts of the state. So we'll go to the next slide. This is perhaps as much for your background as anything, and it is a 1-page history of how the North Sound ACH came into being. And so we were one of the first ACHs in the state of Washington, embedded in some statute in 2015. We were a project of a nonprofit here in the Bellingham area, and then have evolved as the state of Washington went through state innovation model, grant funding, through receipt of the Medicaid waiver, which resulted in the Medicaid Transformation Project. And so the ACH and its governance and the principles that drove it started before that federal funding, and has been challenged along the way by decisions such as a Medicaid waiver. Do you stay thinking broadly about population and community health? Do you all of a sudden narrow yourself into kind of a Medicaid market kind of approach? But if there's anything that jumps out as questions on that, I'm going to skip over some of the detail of our history. The next slide is really if I were to say there were some decisions that were made along the way that have shaped how we have presented a future state discussion to our board, these are the 6 decisions. In our region, we have 8 tribes, and the healthcare authority, so the state Medicaid agency, had requirements for all 9 of the ACHs, and it's that you had to have 1 seat on your board for a tribal representative. And in 2015, the decision had been made to have 1 seat for each of the 8 tribes. As we became more formalized, that was challenged by the state, and we made a decision to continue to have 1 seat, 1 for each of the 8 tribes on our board. And yes, that means 8 of our seats on our board are set and designated for the tribes, but it has come back to be a really great decision. As I mentioned in the history, we started not inside of the Medicaid approach and kind of narrow. And once we got Medicaid funding through the waiver, our board stayed very clear. Not only were the ACHs not just about Medicaid, but we were not just about healthcare. And so it has really influenced the strategies that we put into play. For those who don't know Washington and its Medicaid waiver, it was the 9 ACHs had an opportunity to select from 8 project areas, and they included things ranging from behavioral health integration to dealing with the opioid crisis to oral health, reproductive and maternal child health, chronic disease, and a couple of others. The minimum was 4 ACHs. In order to continue moving forward, had to pick at least 4. And North Sound ended up being the only one of the 9 regions that chose all 8 project areas. And it was heavily influenced by thinking about whole person health and saying it's really hard to separate oral health from opioids, chronic disease from a variety of other things. And so we just said, let's just kind of jump in and do all 8. The 4th one, and I don't know what partnership relationships look like for you in California. Some of our ACH colleagues in Washington do a lot of collecting of data from partners, do in-person audits, financial audits. We actually made a decision, both operationally and at the board level, that our purpose was to build relationships. When anyone asked us, I'd say between 2015 and 2017, what was your sustainability model? Our sustainability model was built on relationships. And that if we could get organizations to get to know each other, work with each other, build relationships and partnerships, we felt that that was more sustainable than taking a $1 billion Medicaid waiver and trying to figure out how is that sustainable. So relationships became kind of one of our key markers as opposed to a lot of audits and data reporting. But anybody who wanted to contract with us was required to embark on a tribal and equity learning journey. So that was built into every contract that we have. We're now just passing 2.5 years of that tribal and equity learning. And as you can imagine, in the last 6 months, it's probably more relevant in how we see how important that journey has been for us and our partners than even though we knew it before. And then the last piece, which only happened a year ago, is that our board made a commitment that the board was going to embark on an equity learning journey. And so really focused on race and social justice issues. And it just means that they are now also pushing for change that 2 or 3 years ago they might not have been pushing for as much. The next slide, which I'm going to just do very briefly, is that the figure at the bottom is how we took 8 project areas that were very kind of implementation focused and turned them into how we approached our initiatives. And it was heavily influenced by the tribe sharing with us the medicine wheel approach. And so when we think about what are the things we're working on, they really are either care coordination, integration, transformation, or capacity building. And we don't necessarily think about oral health, reproductive health, et cetera, et cetera. Next slide. We also sent our board and members of our team to various places to look at different models. And one of those was last fall. We sent a team of about 12 people down to San Diego to one of the gatherings that Live Well San Diego does. I think it's like 1,400 people, 400 partners. It was like pretty amazing to see that kind of breadth and depth. And this is one of the slides that Nick Mascione shared with us and with our board. And when our board members came back from 3 days in San Diego, they said, you know, we have pretty much used this notion of downstream, midstream, upstream a lot as we've talked about our work. But they realized that in order to embed equity in this journey, we actually needed to be talking about the stream. And so how we now talk about the social determinants of health, we're thinking about things that just kind of flow through and flow around a lot of the work that is listed on the sides of this kind of traditional approach to how we think about care. And the next slide. And I apologize, I'm trying to get through this fast to get to the thing that you actually wanted to hear about. We also brought some leaders to the North Sound region, and of those, so Nick Mascione is here kind of up in the upper right corner from Live Well San Diego. We have some really strong partnerships with the tribes in our region and an organization called Children of the Setting Sun, who do a lot of audio, video, storytelling work to go along with addressing things like opioids and alcoholism and other substance use disorders in the tribal nations. In the lower left is John Powell from the Othering and Belonging Institute in Berkeley. And he and his team have actually spent a good part of the last year and a half working with us and with our partners. And then in the lower right-hand corner, Shoma Stout, who was leading the 100 Million Healthier Lives campaign, and a couple of folks from community initiatives. And we have introduced our board and our partners to the Wellbeing of the Nation framework and how that becomes part of our next iteration of work. So the next slide is one that I'm sure you're all familiar with. You know, as we have talked about equity, I just want to give you an idea of like how the conversation has changed in the North Sound region. You know, we have done the very traditional approaches with drawings like this with hundreds of our partners talking about the differences between these two. What ends up happening today when we have these conversations, folks are now going, yeah, those boxes, it's about sharing and distributing resources, but why are these people outside the fence? What is it going to take for them to actually be sitting in a seat? What's it going to take for them to be being on a team? What's it going to take for them to own or manage a team? And we're like literally trying to find some action components out of all of the discussions that we have around equity. Next slide. So from John Powell and the folks at Berkeley, in 2017, we were introduced to this concept of targeted universalism, and it has become It was a part of like almost every decision that we have made, from how to pick among 8 projects, how do we select our partners, what are the things that we're expecting folks to work on and take part in. But it also has influenced how we have shared the dollars that come to our region. We're trying to figure out how to have that be just embedded in every decision, that in order for us to address any of the issues in front of us, that we need to have the ability to have multiple strategies getting everybody to meet the same goal. So I'm going to just go through both the next slide and then move to the following one. This is the well-being in the nation. These are the vital conditions for well-being that we are talking about embedding in North Sound and in our future state. I'll go to the next slide. But these are really the assets that have been built over the last 5 years. And we are a facilitator convener. We do things that cross the counties and the tribes. We distribute resources, and if you want to, you can come back to like how much resources have we had. We've been doing work statewide, so crossing ACH boundaries, and also trying to find ways to coordinate things like project management and some specific partnerships across multiple state agencies. Our guiding principles are probably, there's probably not a whole lot on here that you would not expect to have. The notion of tribal sovereignty and advancing equity, again, those are things that came out of board discussions in 2017. And as the board would make those decisions, we would then take that and it would drive everything that we did operationally. The next slide is really a description of how our board functions. We have some requirements for who needs to sit on our board, which we have grumbled and complained about for 3.5 years. As we got to this discussion of what comes next, we realized, oh my God, we've actually created a fairly unique board of directors. And in our future state, we're probably not going to let go of any of the things that we've been required to have in place, but we'll just build upon those. I'm going to jump to slide 27. Just we'll circle back if there are questions on any of the others. One more. All righty, because this is the question that you posed to me. And so as we were looking at what our future state would be, we have some ideas about what's the work, what our role would be in that work. But very often, even at our board, they would still just go, yeah, but Liz, who's going to pay for this? Like, how do we get to that point? And so when we were describing this to them, we said there's actually kind of we need like a 3-dimensional cube on this, because you can go like, who's going to pay for this and how do they want to pay for it? And you can, put X's in the boxes because there are probably multiple ways that these payers might pay for things. But if you go to the next slide, what you realize is that the challenge is knowing that different people will pay for different things. And so it isn't just a matter of saying, am I going to philanthropy? They're going to give me a grant, so I should be looking at X amount of dollars. It's knowing that philanthropy may want to pay for advocacy, but they may not be all that interested in investing in community partners. And that, we might have membership organizations who are really interested in building capacity, but don't really give a rip about like who's doing data because they've got their own data. And so we had to build a way to think about the potential revenue sources in a bit of a 3-dimensional approach. And so trying to put a complicated but elegant Excel spreadsheet in PowerPoint is fascinating. So I'm going to go to the next slide. We have been using some folks from the Oregon Health Sciences University to help us distribute dollars over the last 3.5 years. And so if I toss these numbers out at you, like we're probably distributing, I'd say between 15 and 18 million dollars a year over the last 3 years to partner organizations. So those are clinical partners, community partners, and we needed to have a way of creating an algorithm that would go, so I want to pay somebody differently if they're doing one initiative versus four, paying them differently if they're in a rural remote area versus they're along the I-5 corridor. They're willing to partner with multiple organizations or they just want to go it alone. The number of Medicaid, the size of their organization. And so we have this very complex algorithm that got put together that allows us to say, out of $18 million, you get $200,000 and you get $78,000. And so we went back to that same group with what we thought would be a much simpler thing. And we said, so how do we take that kind of Rubik's Cube shaped set of questions and try to come up with a simple way for us to estimate both revenue and kind of build in our budget approach. And so it's a 3-step process that they put together. So the first step is really kind of looking at what do we think our total expenses would be in any of the areas. And these are all changeable. So, this might be care coordination and this could be something else, but just like, what would it cost us to do the things that we think that we want to have done, and describing that in whatever way makes sense. And then if you go to the next slide, which is step 2, what we also wanted to do was to try and figure out, is membership an option? And in describing this to our board a couple of weeks ago, it was recognizing that among the partner organizations that we have, that they range from a local family like resource coalition to the YMCA to an independent clinic to Kaiser to the Providence Health System, counties, public health departments. We have a couple of cities. We've got law enforcement that are involved. And depending on who they are and what their own internal systems might be like, one person might be willing to give us $300 and somebody else $50,000 is really simple. And that we had to have a way of somewhat creating tiers of what we thought that annual membership model would be, because how we go and talk to them really depends on what their own situation is like. And so whether you think health plans want to give you $3,000 or health plans want to give you $50,000, like there's something that has to happen internally. But it allows you to see how much of what you think you would need to have in any given year could be derived from a member or partner dues paying system. And so if you go to the next slide, this will be like part 3 of this. And so once you kind of think through your tiers, this all then feeds into this model that takes the first part of what it is that so across the top is, those areas that you thought you were going to be focused on. And then under income sources, what are the estimates that you have for what you can bring in? But it allows you to then go, for membership, we actually think they're willing to pay for these things at these percentages, but not this. They're probably not interested in us incubating and coming up with new ideas, but somebody else might be really interested in that. And it might be somebody who's willing to pay us to be that incubator, to do pilot projects and feasibility studies, et cetera, et cetera. Philanthropy, like what does their percentage look like across those areas that you've set? And you then kind of see at the bottom, have you hit what you thought your target was, or are you still short? And so we, his name is Dan Vizzini, created this template for us. And we have been playing with this in like 1,000 different ways to try and come up with how much of what we think our future state will cost has to be driven by membership. And it could be that it can range from 0 to 20% to half, just depending on what you think members might be willing to pay for. So if you go to the next slide, because I think that it also, we're in a bit of an interesting space. And since you use the word sustainability, it'll be interesting for us to see how this flies for you. But what we said to our board is we have a very traditional organization right now. We're a 501c3. I have 17 staff. They're predominantly doing project management for these Medicaid waiver projects. But then we've got like a bunch of other things that have been going on, especially around some COVID response. And we said to them, we're actually not trying to figure out a way to sustain a 17 FTE organization. What we want to sustain should be based on what does our region need. And so how you build an organization that can kind of flex, shrink and grow, that scares the crap out of some boards, and it might be exciting to other boards. We also said that sustainability is not the frame, and that we just weren't sure that what we had today is what needed to be sustained, because the issues that are at play right now could not have been predicted 6 months ago. And so how you actually can focus on sustaining the functionality as opposed to the entity seems to be really important as we think future state. And then at least for Washington's ACHs, we are just in a unique position because our boards are asking for these future state plans when we are not out of money. So we still have probably 2 to 2.5 years of revenue looking forward in the future. And the reason that this became such an issue for us this year is that the Medicaid waiver ends at the end of 2021. But the way it got structured, the revenue that comes out of the 5-year waiver takes actually 7 years to get to us. So we actually have 2 additional years of revenue on top of finishing the 5-year waiver. So I added in the next slide, just like, this is a drawing that a friend of mine did, I'm going to say 15 years ago, that I have held on to. And, as we have asked, how can we think outside the box? It's like realizing that we are within a box, within a box, within a box. And so, it is always just this remembering that, oh, I forgot that I shouldn't assume anything. I shouldn't assume, that what philanthropy was paying for a year and a half ago might be really different than what philanthropy is willing to invest in looking forward. And so we don't think about funders, we think about investors, we think about not looking for people to pay for what we're doing today, but what it is that we're trying to build looking forward, and for whatever value that insight might be for you. And then on the next slide, we have spent a lot of time asking our partner organizations to tell us what they think the value has been of having a regional entity like an ACH. And so if that's something that you feel like you could get, I would really encourage you to do that, because having them speak for the ACH is worth like 50 of me speaking on behalf of the ACH. But it's a link to it. It's a very like raw video. There's nothing polished about this video. But having the board hear from partners about what was important to them was really critical. So I'm going to just end with this slide, which is about, I'm going to say about 20% of the folks who have taken part in the work that we've done across the North Sound region. We've had about 4, so we're, in our 5 counties, we're about a little over 1 million. We're about 1.2 million people. We've probably had about 500 people who've taken part in the Tribal and Equity Learning Journey. We have 60 partner organizations across the 5 counties. And it has been really pretty incredible to see them building new relationships and partnerships with each other, and recognizing that it's just because the ACH was able to help broker some of that to happen. So Jeremy, I'm going to pause. Feel like I just like.
Great. Yeah. Oh, thank you. That was a lot and done very smoothly in a short time. I'm sure there are a bunch of questions. I wanted to just lift up, well, one, I really appreciate that notion of sort of, what's the right frame, or sort of like, what does sustainability mean? What are we sustaining? I think it's a really important question, and sort of function and goals, not, not an entity specifically is great. And it's funny, I have a Rubik's Cube sitting here, so on my desk that I've been messing with. So that all that description of sort of the 3D challenge, there's a visual, and I think that's a great sort of metaphor for trying to. This is not a sort of 2D linear problem, to try and sort of understand the different interests, the different potential models, and I think your approach is really helpful for that, sort of working on these different axes. And I really like the model, the Excel workbook that you all have put together, and will be interested to apply some of that. So I want to share two questions that came in on the chat that you can answer quickly, and then ask another one while people generate their questions as well. One was about Kitty asked if you could share the contractual language around the equity work with the board. That would be, I think, could be really helpful for us. And Marvin had asked for some more details on members of the board. So, and we can look that up also and share that there. And then I want to build off of actually the question that Pat just chatted in. If you can talk a little bit more about those membership categories, the levels, how you decided kind of on the, the price point for them. And I also curious, sort of if when you get to that next phase, if, they're sort of lumped together, and you said, well, philanthropy might pay for this. Have you gotten feedback from the members that some of them sort of want their membership dues to support specific aspects of your work, or have you tried to push for it sort of to be a pool?
Yeah. So, the piece that we are doing between now and December, talking to different groups really about that specific question. The price points were interesting, and it is trying to figure out, what do organizations pay for today? And what we kept hearing, and I'm going to say from the health plans to the hospitals to the counties, that people pay member dues to be part of things that they don't find great value in. And so in Washington, as an example, the health plans pay to support an organization that does some analysis of Medicaid data statewide. And through COVID, they've been going, oh my God, if I took that, and I think that it probably is somewhere in the $50,000, $60,000 a year range. If I could take those funds, give them to the ACHs to help coordinate COVID response, would do that in a heartbeat. And so for us, part of the exploration is like, what are they paying for now, and not like really just not thinking about it because it's been normalized. So, nonprofits will pay to be a part of a nonprofit association, and it's based on a sliding scale based on your annual revenue. I think of, PHI and the National Network of Public Health Institutes. Any of the public health institutes pay a member fee to be a part of the national network. And when you start looking at what are you already paying, so without necessarily feeling a value in return, our partners have started to identify the number of things that they already pay for. And so if you then can give a value on top of turning to a county. So, I mean, I can kind of tell you, like, if you were to go back to, maybe it's like slide 30, if you were looking at categories 1, 2, 3, 4, like, we're probably going category 1, your typical community-based organization, from a community action to the YMCA to, just kind of those organizations. And number two was probably individual primary care behavioral health practices. They kind of fell between a 1 and a 2. Like, what is possible for them to actually pay for? 3 is where you got to like your bigger clinics, bigger organizations. And then we had the hospitals, and we've got the health plans. I think those are the ones that we kind of have brainstormed so far, that those are kind of some of the categories. And the challenge for us is that every one of them is a one-off. So we needed to then say, how do we go to them and ask them, what's your threshold for what you might pay? And we need to have the other side of that Rubik's Cube. What would you be expecting back if you paid $50 a month versus $100 a month? Like, do you expect something in return? And the things that they have kept coming back to, you're like doing all the organizing to pull us together when you've got, you know, a Shoma Stout coming to town. You're willing to just tell us like 4 weeks ahead of time, it's on a Thursday from 2 to 4. Like, if we did that much for them to keep them in the loop on what's current and what should be pushing the envelope for them, they saw a value in that. For, you know, and again, I'm going to assume this is true in California, but, you know, we have contracts, I'm going to say, with maybe 8 or 9 community paramedicine programs. They're all separate operating districts with their own boards, their own governance, and no one had ever pulled them together. So we're talking about community paramedicine as part of a model. And the notion that they have been able to get, whether in a room or on a call, like, they have seen such amazing value. It has changed the way they're approaching the next legislative session, trying to figure out how come paramedics can intubate somebody, but they can't give them a flu shot. You know, they just have been having these like amazing conversations that seem incredibly small and benign, except when you realize they've never had those conversations before, not across jurisdictions, across those centers. With COVID, where what has really been elevated, and if you guys don't mind, I want to stay on the call for your CARES funding conversation. But, you know, we have 5 counties, therefore we have 5 local health jurisdictions, and almost everything that has happened at the county level. And because of the map of our region, like if you were on one of the islands in the North Sound region, literally you have to go through another county in order to get to the hospital that is in the county in your region. And so nothing happens because you're on this side or that side of the county line. And when we pulled in some, you know, ability to look at COVID, both test results, hospitalization, surge numbers, response, recovery information, looking at it at a regional level as opposed to a county level, every one of the counties just kind of did this whole like poof kind of thing of, we didn't have the ability to look beyond our county in order to pull that together. And so they have just continued to tell us there are some of those pieces they're willing to pay for. And if a dues approach works for them over a contract, where they saw the dues being more valuable, that the contract isn't organization, the contracts are more organization specific, whereas a member or partner dues model is really more at the core of what you're doing broadly across the entity. And there was just they could just see value in both of those.
Great. Thank you. To get some other voices in here, Jason, looked like you texted in a question, but if you're willing to unmute and ask it, that'd be great. And if others, just to keep the queue, I mean, you can either chat it in or raise your hand, or the next pause, just jump in.
Sure, and I think Pat had a question as well, but I'll ask mine first. So just you talked about the relationship building and that it has led to this willingness to look at the membership model, or at least willingness to share information about membership levels. And I just wonder, maybe I missed it, but was membership always part of what you expected would happen for sustainability, or did it come out of these conversations over time?
It's such a great question, and a membership, here's my like sarcastic answer. A membership model is easier to discuss before you bring $100 million to the region. So if you can imagine, I am overseeing an entity that knows its revenue for the next 3 years. And so for me to be talking about, hey, I need you to give me $3,000 when this year I'm giving you $50,000. It was part of the conversation prior to the Medicaid waiver, and it has stayed a part of the conversation even though we paused it while we had these funds. And so we have I think it's part of the why we haven't been thinking about sustainability as much as what's the next phase of this work. We have always been saying to our board and partners, you get to determine what the value add is because you're the ones that have to sustain it. So we've had it as part of the conversation from the beginning.
Thank you.
Okay, we got a couple more. Thanks, Jason. A couple more coming in. So Barb, you want to ask your question, and then Allison?
Sure. Thank you so much. This has been a terrific presentation. You talked about the role of the ACH in bringing the community paramedics together as something they recognize to be of value to them. And in thinking about what people might be willing to pay for in identifying things that are valuable to them. I'm wondering if there are other things, other aspects of the ACH's work that you think fall into that category of what's valuable to your partners that they might be willing to pay for, even if you don't know that for certain right now, what you think they might be willing to pay for.
Yeah. We know that the health plans are I'm going to put it probably willing to pay for some elements of coordinating care coordination. They're a little, it's a good word, they're kind of squidgy to pin down. But they have been a part of, and I'm going to say for the last 4 years, like what would be the role of a hub? So if I use those community paramedics as an example, we actually have 4 care coordination projects that are part of our Medicaid waiver. And we have been trying to build a hub that connects those. So the notion that a community paramedic might be called out and not know that, whether it's the housing folks are working with that same family or the hospital just discharged them. So we know that there's a value in there. Trying to put a dollar amount on that has been challenging. And as you can imagine, it would be really different if the health plans came back and said, we want to do this as a per member per month, as opposed to we want to give you a grant or we want to do a contract with you in some other way. But so care coordination has been a really big one. What we have been asked probably most in the last 3 months, training and education around building a culture of equity and leadership among organizations. And we've been asked that from hospitals, county executives, and the local health jurisdictions. They've always thought they were doing a great job until they wanted to do something really simple, like put out a public statement about racism. And they have been caught off guard by how unprepared their organizations are to make a public statement. Mm-hmm. So I think the training and education has been one piece. The data collection, visualization, sharing data that crosses the tribes and the state and counties, because the tribes have some data sovereignty, components that sometimes the state addresses and sometimes they don't. So our relationships with the tribes has been really important. So we've had the tribes coming to us and asking us to be the bridge between some of those components, and so going back to them and talking about, you know, what's the pain point for helping to assure that an entity is available to do that. They're in those conversations with us as well.
Thank you. That's great.
Great, thanks. We've got about 5 more minutes or so, but now that I know, Liz, that you're going to stay with us for the CARES Act portion, I can feel a little less urgent about getting right to the end. So we could take a few more, definitely. So Allison, you're next.
Does each agency have a vote, or do you have agencies with multiple people on them who are able to carry a vote? How does that work on your board?
On the board, every board member has one vote. Sorry, I know exactly kind of where your question is going. And it was when the board made the decision, 1 seat for each of the tribes, that there was probably a pretty high level of anxiety that somehow the tribes would overtake the board and they would like glom together and vote as a block. And it's been really clear that that is unlikely to happen because we're talking 8 tribal sovereign nations who all approach things very different from each other. So we have some sectors on our board. So we have the hospital sector, public health sector, primary care, behavioral health, and those sectors actually come together and nominate someone to be on the board. So they would have 1 vote. So we, for example, we don't have 2 hospitals on the board. We only have 1 person from public health. And so we've never run into a situation where an organization is trying to do a vote in any way because of the way the board is structured. We just haven't had that come up. And I think somebody asked earlier about like how many people are on our board. At the moment, our bylaws allow for 23 board members. I believe we currently have like 18 or so. And again, 8 of those seats are for tribes.
So can you just quick the distinction then between, like, looking at the slide we're looking at has 57 members. Does that include all the board members plus?
No, this actually has nothing to do with the board. This was, when we're thinking about membership, we're thinking about partner organizations, of which we currently have 64. So this is really, so this would be the 5 counties, the 5 public health jurisdictions. We have 7 hospitals, 5 health plans. The rest, really kind of the clinical and community-based organizations. So this is really thinking more about our that's why we have kind of members / partners, all of the organizations that we work with.
Got it. Great.
Yeah.
Cool. Okay. We've had a couple more come in. Maybe I'm going to combine. Oh, good. Okay. So Catherine, you had 2 different questions. Why don't you jump in with both of those, and then we'll go to Deborah and Pat.
Thanks, Jeremy. Yeah, I was curious about how your ACH got Medicaid waiver dollars to begin with, and then also whether you are including any employer members. In Sonoma County, we're definitely considering large employers as stakeholders in the ACH work, and I didn't hear you mention them.
Yep. So as part of the SIM grant, so the Washington had 4 years of SIM grant funds that overlapped with the first year of the Medicaid waiver. And so the SIM money was not very much, but the Medicaid waiver was probably for Washington close to $1 billion. And so it was SIM that set up the 9 ACH regions. So we were operating for the 3 years prior to the waiver And what the state did in the waivers, they distributed the dollars based on Medicaid population. And North Sound is second behind King County. So whatever waiver dollars came to the state, we got 15% of them if we met our metrics and all of our deliverables. So we knew from the beginning of the waiver what our potential earning was for the region, as did all of the other ACH regions.
And then the question about employer.
Oh, the employers.
Members.
Yeah, so we have, I'm going to say through 2020, I have two, and I'm going to try not to make it sound like I'm being duplicitous, but two answers. One is we have not reached out to the employer leadership. It is definitely part of our sustainability strategy and our looking forward. At the same time I say that, I know that in each of our 5 counties, the county and the health systems are the largest employers. So in Snohomish County, if I don't include Boeing, we have the partners who are the largest employers. We just have never spoken to them as employers. We only speak to them as part of the delivery system. And so our board is very aware of the fact that if I were to go, for example, to Providence Health System as an employer, they might find money that Providence as the hospital and physician delivery system might not. Because the employer is going to go, how can you hit and help my 5,000 employees? And so what we know is that we actually have some good relationship with large employers. We have not actually had a conversation with them about their employees. We've only been thinking, if I go back to that box, we've only been thinking about them as the delivery system. And so the board is really pushing us to change that frame within which we talk to even our partner organizations.
Thank you.
Great, thanks. Okay, we got 1 minute left. So last question, I'm gonna ask to Deborah if you want to ask your question, and then we'll wrap up.
All right. Thank you, Liz. Great presentation, good information. My question is basically, can you talk a little bit about your data collection or your evaluation that you built into the ACH program or your model?
Yeah, I can. And
Easy 1 minute question.
Right? I know, really. The good news is I'm not a data, no. But so the way that the Medicaid waiver worked in Washington, all of our metrics are based on data that the state is collecting and not on data that the ACHs are collecting. And so it allowed us to do that focus on the relationship piece and not the data collection piece, because no data that we were collecting was going to make a difference in how we were valued, which is the terminology for our earnings. And so the things that we collect in terms of data are probably about as simple can be. They are, is there anything getting in the way of you being able to reach people who are like suffering with opioid use disorder? What's getting in the way of the interventions that you're trying to do? What have you tried? How can the ACH help? And it has been really stunning for us to know that we're using, for example, the MEHAF, which is looking at some integration and a statewide opioid survey. And providers are reluctant to complete those surveys for the state, yet they're willing to tell us all of the challenges that they have in meeting the requirements that are at play, because nothing that they tell us is being held against them. And so we have kind of the state doing all of the quantitative data collection. We are doing an amazing amount of qualitative data collection where we know that people are incredibly committed to doing the work. and the things that are getting in the way. So we've been able to focus, and I think it ties to this future state discussion. We've been able to tie everything we've invested in to what partners have told us getting in the way. Like part of our job is to mitigate what's in the way of them doing a better job. And so that's what we have focused our data collection on.
Thank you.
Great. Thank you so much. I feel like there are a whole bunch of other avenues we could go down and threads, but this is also the beginning of a conversation. I would encourage folks to, if you have additional questions for Liz, well, you can chat them in the next half hour, but definitely send them to me. We'll share certainly the slides. Liz has shared some other resources with me if folks want to play with that spreadsheet model. I'm happy to do that with you, and then when we get stuck, to get in touch with Liz. But thank you so much. This has really been so helpful, and it's it's great to have this sort of exchange as we're all sort of trying to navigate this landscape and strategies. So actually, I'll ask folks if you're so inclined. We can't really do a round of applause effectively, but you have the little applause emoji. So down at the bottom of your screen, reactions. If you want to give Liz a round of applause, we really appreciate your time.
Yeah, well, and can I ditto the thanks back, because certainly, and I spent like 35 years in Oregon, so watching how Oregon has developed its CCO model, really different than how Washington has approached the ACHs. It sounds very different than what California has been doing. And, for me, the excitement is if we could get California, Oregon, and Washington, pushing in some common directions, that would be really amazing. So getting to learn more about what's happening in California, that is just a real plus for me as well. So thank you.
Well, we owe you one. So when you need anybody on this call to come present to your team.
Thank you.
Great. Yeah. So we're gonna transition to talking about CARES Act. Again, be super quick. This is it's a topic that's come up quite a bit recently. I think a lot of us are thinking about, and Liz just referenced in her presentation as well, sort of what the pandemic means, where there are opportunities, and some of the questions that are being raised about the value of coordination in this moment. It really does seem like it lines up in a lot of ways with the intent of CACHI. So Erin's going to talk quickly, kind of a high-level overview of CARES Act funding. Then Tiffany will talk a bit about what's going on in Long Beach, and then Jason will comment on South Stockton and Sacramento. And again, we'll have a few minutes at the end. Feel free at any point to chat in questions, and we'll track those as we go. So turn it over to Erin.
Erin, we can't hear you if you're speaking.
I think you're, yeah,
sorry, I had to unmute in two places. Can you hear me now?
Yes.
Okay, great. So I'll be pretty quick. I know we're all vaguely familiar or intimately familiar with the CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act. It's the largest economic stimulus act in modern history at over $2 trillion. And this visual shows just some of where the money flows to. I'm sure we've all heard about the direct payments to individuals, to large businesses like airlines. And today I'll be focusing on money to states and municipalities, which totals about $175 billion. And the CARES Act created the Coronavirus Relief Fund, which is meant for states and also tribal governments and territories. And the relief funding from the federal government is based on the size of the population. So in California, we're expected to receive about $15.3 billion. And of that amount, $5.8 billion is expected to go to cities and to counties. And again, based on population. And the intended use of these funds is for expenditures that were incurred in response to COVID. And these expenditures have to meet a couple different criteria. One is that they're necessary expenditures for COVID, or that came up as a result of COVID. Another is that these expenditures can't be, they can't have been accounted for in the most recently developed budget as of March 27th of 2020, which is when the CARES Act was passed. And the funds have to be incurred between March of 2020 and December 30th of 2020. So all pretty fast and all within this year for now. So next slide, please. So this visual just gives an overview of how the money will flow, and I'll just focus again on state and local governments. So funding for state governments comes directly from the feds. And then for local governments, it can either come directly from the feds if the population is over 500,000 people, or if the local government represents less than 500,000 people, the money would go through the state, then to local governments. And the CARES Act doesn't specify that the state is required to distribute funds to local governments with less than that 500,000 mark. And states have discretion in how they distribute funds to local governments, and it can tailor their distribution in a way that they see fit. And another important point is that for funds that flow directly to local governments, they have a cap of a maximum of 45%, and then the state receives the remaining amount, the remaining 55%. And the idea there is that the state is also serving those populations in municipalities with more than 500,000 people. If you could go to the next slide, please. So again, the CARES Act funding can be used for a variety of needs, including public health COVID response, and also things like mental health and substance use needs, community behavioral health, and also addressing homelessness. And this table on the right is from the Legislative Analyst Office in California. The LAO has a lot of information on federal relief as it relates to COVID, and this is from one of their reports. And it shows the different, you can see the state government funding amount, but it also shows the different local governments that are eligible for direct funding. And so those are the ones that meet that 500,000 population threshold. And one other detail is that if like a city and a county like Fresno or Los Angeles were to apply for funds, the city would relieve funds based on the amount of the population. And then the county, like LA County, would receive funds for the county minus the population of the city. And in California, in the state budget for 2020 to 2021, they created some more stipulations for local funding to local governments. So California has set aside funding for local governments with a dividing population line of 300,000 people. So there's 225 million set aside for local governments with over 300,000 people in California. And for local governments with fewer than 300,000 people, there's $275 million set aside. And if you could go to the next slide, I think, oh, sorry, that's the last slide. And the process for this is that cities and counties apply to the Department of Finance, actually by July 10th, so the timeline has passed, to receive these funds. And then the Department of Finance ensures that they're complying with federal requirements, and I think then disperses the funds. So a really fast timeline, definitely evolving. There will likely be more stimulus, but we're unsure what form it will take, but this is just a quick overview to explain mostly how the money flows from the feds to the state and local level. And that's it for me.
Great. Thank you, Erin. Thanks for that overview. And I think those last points are key where we are in the process, and that this is moving fast, decisions are being made quickly, and that there's potentially, there will likely be additional funds in the future. So so figuring out the channels and decision making and where the tables are is valuable both in the short term, but also in the long term. So thanks very much for that overview. So why don't we turn to Tiffany and then we'll keep tracking the questions.
Hi, I'm Tiffany, and I work for the City of Long Beach Department of Health and Human Services. And as it relates to CACHI, I work with the backbone organization for All Children Thrive Long Beach. Next slide, please. So just really, I want to go through this quickly because I want to talk more about the opportunities for everyone else. Our process, it was very rushed. We worked through our Emergency Operations Center. In our operations section, we set up a resiliency and recovery group, which was led by the health department. It had city staff from different departments weighing in, but I will admit that that resiliency group was entirely led by city staff. And we were pulling together how we might utilize these funds in our community. Long Beach is the largest city in California that did not receive a direct allocation from the federal government. We are 475,000 people, so just shy of that $500,000 mark. And, you know, we had a lot to say about that. So it was good for us to have an opportunity to get funding directly from the state for such a large community. It was up to the staff to seek input from community and stakeholders, again, very, very quickly. And I think this is where, for us, the opportunity of having our ACH so closely connected to the health department was beneficial, because we were able to connect with our ACH and get feedback from stakeholders in that way very quickly. There were multiple iterations of planning that was sent to, and recommendations that were sent to the city manager. The city manager presented this to our city council twice, in June and July, and of course our elected officials weighed in on what they thought would be the best use of funds. And I will say that some things like snuck in that weren't in our initial planning, such as a $1.5 million fund for grants to the arts community. So that's in there now. And I won't worry too much about the next steps. You can go to the next slide, please. So All Children Thrive is our accountable community of health. It is, the backbone is our city-led health department. And so California has 3 city-led health departments. The rest are all counties. Long Beach is one of those. So this is like unique and unique in our situation. We have a network of organizations that are part of our ACH already. And again, we were able to pull on that very quickly. We have the school district as part of our accountable community of health. We have the largest federally qualified health center in Long Beach. We have mental health organizations serving children and their families. We have a collaborative of early childhood education providers that is also looped into our accountable community of health. And then we have, I think a lot of you are familiar with the Building Healthy Communities programs throughout the state that's funded by the California Endowment. One of those for Long Beach is also in our accountable community of health, All Children Thrive. So we had these organizations together, we had these relationships already, and through that network of organizations and also family leaders who are in our community, we're able to move really quickly toward a common goal. So we didn't have to spend a lot of time agreeing on what this goal was and how we could be utilizing the CARES funding as an investment in our community. Next slide, please. So what Long Beach has decided for the utilization or the priorities of our CARES Act funding, which is a $40.28 million, 48% of that is going towards the emergency response we've set up for COVID. So a lot of that is really like testing, some contact tracing, and other things that weren't immediately funded by the CDC, as well as a lot of sheltering opportunities we have for homeless individuals, and also isolation shelter for housed individuals, which is something we do offer in our jurisdiction. 16% of the funding is going towards business recovery and resiliency. I think things to note there is there's a PPE distribution program that's for businesses and also nonprofits and even early childhood providers. And then there's a lot of some more small business grants that were going out there. And interestingly, they were able to get an economic equity study out of that, which will hopefully be something that's a little more sustainable and carry us into how we can redesign these things for the next year. But the community support got 36%, and that's really where the opportunities are for our ACH and for a lot of the programs that at least my department touches. So we have a basic needs resource line that we'll be setting up through this funding, and that was also something that our ACH had been requesting to have. Not that they called it a basic needs line, but a way that all of our providers could really be having like a no wrong door kind of entry point for families, and to be able to route them to the services that they need. And right now, those services and those needs have only increased for housing, for maybe job retraining, for finding childhood education spots for their children, food. The list of needs is overwhelming right now. Food security and meal delivery programs also is receiving funding, as well as older adult supports. We were able to get housing condition improvements, which is very special, looking at housing conditions that exacerbate illnesses that are related to COVID-19. So a lot of like mold remediation, air ventilating, things like that, which are really, for us, some environmental justice and other issues in our community. We have a mental health and domestic violence bucket of funding. We have a Black Health Education Fund. We have early childhood and youth programming supports. We have digital inclusion, which was included, and I think very important. There's a nonprofit relief fund, and then there's also that grants to the arts community that got put in there. You can click on that link and find more information on our website, as well as an opportunity for other nonprofits and to express interest in participating in any of this work, because we have to figure out how to get the money out the door. Next slide, please. So I think the lessons for other communities, because like Jeremy said, a lot of this has already been, organized and somewhat decided, but I think, for future funds that come to governments, it's really for your ACHs to be able to utilize the existing relationships that you might have with city or county government. And by that, I mean staff and managers, because we are sort of the worker bees that are trying to organize this work. And then, of course, engaging with elected officials, which is where your community can really come in and push for things that are most important for your residents and for your constituents. And our elected officials were very responsive to that. And I hope that that would be the case in your communities as well. What I really tried to think back to, what was important for our work was the messaging that we had to other like higher city officials and also elected officials, and kind of the value proposition that some of your ACHs may take in this work is, how do we use the CARES Act funding, or whatever future funding mechanisms come down? How do we use this to build something better that will be sustained beyond December 2020? And really, this is not a backfill, because some communities did think of it as, oh, okay, we're just going to backfill, emergency responders or something. And that, you can use the funds for that, but that's not going to get you anywhere further come January when you can't use the funds anymore. So really, this should be an investment opportunity to try to create something more sustainable and something better for our communities. I think we all can think of ways where COVID has really exposed the cracks in our system and turned them into giant rifts that everyone's falling through. So how do we build something better so that that doesn't happen to our communities again? And then, at least in the CARES Act funding, we are like under a lot of pressure to get this money spent and out the door by December 30th. And whatever, if we don't spend it, or if we don't spend it properly, it's going to get taken away. And that's an investment that is not made into our Long Beach area. So as non-government organizations, each of your ACHs already has a network of organizations and members and community partners who are already collaborating in a sustainable network. And I think your value proposition is that you can utilize CARES Act funding very quickly to reach those most in need. Definitely a lot more nimble and agile than government agencies. So I think that's the angle that has been, I think, beneficial for nonprofit organizations in Long Beach. And I hope that that would be the case for some of your communities. So I'll open it up, I guess, to any questions.
Great, thanks so much, Tiffany. Let's shift. Jason, you're up next.
Sure.
And we're a little short on time, so
okay.
You can keep it to 3 or 4 minutes, that would be great.
Yeah. I'll move quickly. And also just let people know I'm using these examples not as the details are going to be different in your community, but just as ways to kind of show what's happening. And to say thanks to the others for all of the observations they put in there. I want to emphasize a couple of really important things that I've observed with CARES Act funding generally and with the information that you just heard. One of them is, and we need to really emphasize this, to my knowledge, the funds are going to have to be spent by December 31. So anything your county or city is funding needs to be done and spent by that time. And that puts a lot of pressure on the systems to get the money out. Meanwhile, the feds are changing the rules every day. I'm hearing from folks in the city of Sacramento that they're getting new rules all the time. And their city attorneys are determining what the money can and can't be used for and what the processes need to be that are changing as well as they get more information. And so what this has caused is a lot of delay and kind of paralysis, and that the money is really going out, and I think this lines up with what the others have said, through existing systems, your existing county departments, your existing city structures. It's internal staff conversations that are mostly happening. It's not out in public because, for the most part, because it can't be, or at least it hasn't been the way to go with all the other pressures they're facing. And also the other difference is there's a huge difference, it seems to me, between what counties are doing with the money and what cities that receive the funds directly are able to do. And that comes a lot because